Vanakkam. There was a report in October 2013 entitled A Review of the NHS Hospital's Complaints System, Putting Patients Back in the Picture. And this report stated the top 5 reasons for complaints in NHS hospitals. The first complaint was lack of information. Patients said they felt uninformed about their care and treatment. The second was compassion. Patients said that they had not been treated with the compassion they deserve. Third was dignity and care. Patients said that they felt neglected and not listened to. And fourth was staff attitudes. Patients said that they felt no one was in charge on the ward and the staff were too busy to care for them. And finally, resources, where the patient said that there was a lack of basic supplies like extra blankets and pillows. Of these 5, the first 4 important reasons for complaints from patients about health care was not the lack of treatment. It was all about lack of communication. But as doctors and surgeons, we feel we have informed everything to the patient. Why is it that they have complained like this? George Bernard Shaw said, "The single biggest problem in communication is the illusion that it has already taken place." So we need to understand that the two words information and communication are often used interchangeably, but they signify quite different things. Information is giving out. Communication is getting through, as Sidney Harris said. Historically, communication has always been described as a secondary or a soft skill for surgeons. Now, astute communication, both with patients and colleagues, forms a fundamental element of holistic surgical practice and comprises a core component of what are known as the non-technical skills for surgeons. And this is being increasingly recognized in modern surgical practice. Good communication is required during each patient interaction, history taking, counseling, even during the explanation of the procedure or explanation of the problem to the patient, consent taking, breaking bad news, and managing difficult encounters such as demanding or angry patient. Good communication with patients improves patient trust, patient compliance, overall satisfaction, and reduces complaints and malpractice claims. It is not only for communication with the patient, but high quality communication is also fundamental when interacting with colleagues in the operation theatre, in the ward, whilst making referrals to other surgeons and organizing special tests. In the busy schedules of medical professionals, such communication must be succinct and relevant. Suboptimal communication is a root cause for the majority of serious adverse events in teams. And good communication reduces job stress and enhances satisfaction for not only the surgeon but all the members of the surgical team. As far as medical students are concerned, communication skills are very important because it helps them to ace exams like the MRCS exam and other competitive exams, because the importance of role-playing format in questions is becoming very popular. Like for instance, how would the student go and break a bad news to a patient attender? How he would address an angry patient? How the student would go and discuss a medical error with the patient? And how would the student make a challenging emotional conversation with the patient and the family? I know a lot of wonderful surgeons who say, I can do a good surgery, but I am not a good communicator. What can I do? There is good news for everyone. Good communication is not an inborn behavior alone. It is a skill that can be learned based on key principles. Program Director Walter Bailey, professor in the Department of Behavioral Science and Faculty Development, and his team at the MD Anderson Cancer Center, University of Texas, have evolved the I Care interpersonal communication and relationship enhancement, which deals with the basic principles of how to communicate with patients. And they have described many situations in which communication is very important. I shall talk about a few situations so that we are able to understand the importance of communication in the day-to-day practice of medical professionals. The first important situation is the primary interview or talking with the patient when they come for a consultation, and it is called the CLASS protocol. C refers to the context, that is the setting in which the interview is occurring or the consultation is occurring. It needs to be a private area with no distractions. If you are talking to a very high official, would you or the official like distractions? It is the same here. The patient is the most important person in this interview. He or she must not have any distractions. So you need to choose an area where you can have a private conversation. Your eyes should be at the same level as the patient or the family member. Both must be sitting down and comfortable with no physical barriers between you. If family members are also present, it is the patient who should be seated closest to you. And you need to present yourself in a relaxed demeanor and maintain eye contact except when the patient becomes upset. You can touch the patient, but only a non-threatening area like the hand or forearm, taking into considerations the cultural issues that may not allow touching. At this point, we also need to remember that if a male doctor is examining or interviewing a female patient, there must be either a family member or a female nurse present in the room. It also holds good for female physicians or doctors examining male patients. The L in CLASS stands for listening skills. The first important thing before communication is to be an effective listener. You can start off with an open-ended question like, how was your new treatment? Do you have any concerns? Please tell me. Or how have you been feeling? And after asking the question, you need to allow the patient to speak without interrupting them. And you also need to convey to them that you're listening by occasionally nodding to the patient. And also repeat a key word from the patient's last sentence in the first sentence that you speak. Then clarify what the patient is saying by saying, so, if I understand you correctly, or tell me more about. If there are time constraints, let the patient know ahead of time. This consultation is for half an hour. And if you get phone calls in the middle, don't answer. But if you must answer, apologize to the patient before answering. You should communicate to the patient that you are completely listening to the patient. This is a very important aspect of communication. No patient is going to talk as if he or she is a zombie. Everybody is a human being, they have emotions. So, when there are emotions, you have to use the A, that is, you have to acknowledge emotions. First, identify the emotion. Identify the cause of the emotion. Respond by showing that you have made the connection between the emotion and the cause. Like you can say, that must have felt terrible when such and such a thing happened. Or most people would be upset about this problem that you are encountering. But remember, you don't have to have the same feelings as the patient. You don't have to agree with the patient's feelings. That is what is called empathy. Now you have gone through the patient's history, examined the patient, and it is time to make a strategy. You need to propose a plan that the patient will understand. First, appraise in your mind or clarify with the patient their expectations of treatment and outcome. Decide what is the best medical plan for the patient and also recommend a strategy on how to proceed. Once you say this, evaluate the patient's response. Collaborate along with the patient and agree on the plan. And make sure that the patient repeats what you have said in his own words so that you get to know what he has understood. While finishing the consultation or the interview, we need to make a summary so that everybody knows where they are standing. You need to summarize the discussion in a clear and concise manner. This is very important when finishing a consultation. Check the patient's understanding. Ask if the patient has any other questions for you. I know a very good friend of mine, a leading consultant, who was voted as the most popular consultant in the hospital. And the most important point that the patient said was, this consultant would ask at the end of his consultation, do you have any other questions for me? But if the consultation time is over, or if you don't have time for further questions, suggest that they can be addressed at the next appointment. This is to make sure that the patient is always open to give his ideas or his feelings to the consultant. And always, before concluding, make a clear contract for a follow-up visit. When, where, and at what time. Sometimes doctors have to break bad news to the patient. This must be done very carefully. For example, you may have to tell your patient, your biopsy report has come out as malignancy or cancer. What you are going to say is absolute truth, but the way in which it is communicated to the patient is very important, and the spike protocol helps in this. First, you need to make a setting for this important discussion. It must be in a quiet, undisturbed area, and you need to prepare for what to say and anticipate the patient or family reaction. In the consultation room, we must have the key people whom the patient wants, and the patient must be sitting closest to us with no physical barriers between us. And as in the primary interview, we both need to be sitting down, try to be calm, and importantly, make eye contact. Before actually breaking the bad news, we need to have a perception of what is the patient's understanding of the seriousness of their condition. Like you can ask, tell me what you understand about your condition so far. What did the other doctors tell you? Assess the patient and family members' level of understanding the problem. Take note of discrepancies in the patient's understanding and what is actually true. Watch for signs of denial. Now that you have perceived what the patient has understood, you need to go about talking. And before that, you need to make an invitation. That is, you need to get a permission to have a discussion. First, we need to ask the patient if they want to know the details of the medical condition or treatment, because patients have a right not to know. You can always say, I'd like to go over the results. Would that be okay? Today my plan is to discuss such and such a thing. Is that okay? And if the patient or the family member has any questions at this point, we need to answer them right away before going into what we are going to say. After all that is cleared, we can start talking and providing them with the knowledge or explaining the facts. We need to avoid medical jargon and explain the facts in a manner that they will understand. For instance, it is not correct to say you have a nuclear grade IER PR positive speculated 4 centimeter lesion in your breast. It is better to say you have a fairly good sized tumor in your breast. After giving the information, we need to fill in any gaps that were evident in the perception stage. And we need to present the information in small chunks, not give everything as a big avalanche. After every chunk of information that we give, we need to verify the patient's understanding by asking questions like, are you with me so far? Have you understood what I have said? Now that you have got your information or bad news across, be prepared for emotions. Emotions are natural, emotions are normal from the patient. What is expected from you as the treating doctor or surgeon is the empathetic response, that is to be supportive. Deal with the emotions as they occur. Patients who are very emotional will not comprehend what you say. Use open-minded and direct questions to explore what the patient is feeling. Like for instance, you can ask, can you tell me more about how you feel? Respond to emotions with empathetic and affirming statements like, I can see you weren't expecting this. Or a statement like, most people would be upset finding this out. I understand totally. Use tell me more statements. Get the patient to talk. When the patients are allowed to talk and vent their feelings, they feel better. They feel satisfied. For instance, if the patient says, I don't know how I'm going to tell my kids that I have this problem, what you should not say is, that is not my problem. What you should say as the treating doctor is, tell me more about that. How many kids do you have? How do you propose to talk to them? Through all this, the doctor also is going to have his own or her own emotions. Try to keep your own emotions from taking over. Avoid responding with false reassurance, like everything will be fine. I have seen a lot of miracles happen. These sort of statements do not help in the long run. Having conveyed the bad news and having responded to the emotions of the patient in reaction to the bad news, it is now time to make a strategy and summarize to close the interview. You need to decide on a strategy of what would be the best medical plan for the patient. Clarify with the patient their expectations of treatment and outcome and recommend a strategy on how to proceed. Collaborate and agree on the plan and ask the patient to repeat to you their understanding of the plan and always document it. Have a very clear treatment plan in writing for the patient to take home with them. And finally, summarize the conversation that you have had so far with the patient. There will be some questions again. The patient may ask, does this mean I am going to die? The appropriate response should be, tell me more about what concerns you. If the patient asks, can I be cured? The correct response again here would be, I am sorry to say that it is unlikely. Our goal is to keep it in check. Or if the patient asks, how long do I have to live? The appropriate response from the doctor should be, I can discuss that with you, but first tell me why you ask. In going through the treatment, medical errors can occur. After all, everybody is a human. But discussing this medical error with the patient should be done very carefully. Yes, an error has occurred and yes, it should be informed to the patient. But how is it to be done? The CONES protocol helps. The most important point to remember is that when a medical error is to be discussed with the patient, it should be delivered by the most senior person on the team that is treating the patient. As usual, the most important thing is the context, the place where the interview is going to occur. Be prepared first for what to say and anticipate the patient or family reaction. And have the conversation in a quiet, undisturbed area with the patient seated closest to you with no physical barriers between you and the patient. Both the doctor and the patient should be seated. The informing doctor should maintain eye contact with the patient. Next, make an opening shot. This is going to alert the patient or the family member of important news. You can say, this is difficult. I have to tell you what I found out about why your mother is so ill. Or, this is hard, but I have some information to give you that is important. Once the patient or the family member is braced for receiving the information, start with a narrative approach. You can explain the chronological sequence of events. Like you can say, as you know, your mother came in for this problem. We gave her this and there was little improvement. Last night we did this and I just found out that, in other words, she received too much chemotherapy. While making this narration, avoid assigning blame or making excuses. Emphasize that you are investigating on how the error occurred. It is good to say we started investigations, and by the end of today I hope to be able to answer your questions as clearly as possible. Or I hope by the end of today she will turn the corner and start improving. And finally, offer a clear apology. I am really sorry that this has happened. You are going to have emotions to what you are talking. Address strong emotions with empathic responses. Use statements like, I know it's upsetting for you, it's awful for me too. Or, it's very rare, but it does happen, and I'm sorry to say that it did. At this point, you should be very beware of being pushed into making promises that you can't deliver. Avoid reassuring the person that there is going to be a good outcome or that no harm was done. Accept the harm that has been done, accept that the result may not be good, and make sure that this is communicated to the patient or the family member. And finally, strategize and summarize. Summarize the discussion and make specific plans for follow-up. Communicate to the patient or the family member that the situation is a priority. You can say, I am the doctor responsible for your mother, so it is important that I found out what happened. I can guarantee that we will do our best. Here is what I propose we do. Let's meet again at the end of today, or I can call you when I know more. If you don't know the answer, say so and that you will attempt to find out. Disclosing medical errors is now a standard. It's not optional. So you must know how to disclose medical errors and communicate that an error has occurred is a very important part daily practice. Sensitive disclosures have a very favorable impact on malpractice claims. Be open with the problem that has occurred. The patients will mostly understand. Encounters with patients who are highly emotional, like when they are highly upset or highly angry, are very challenging. Follow the EVE protocol. Explore the emotion, validate the emotion, and give an empathic response. First, explore and identify the emotion. Is it anger? Is it sadness? Find out more about the emotion and what is causing it. Like by asking a question like, please tell me more about how you feel. Acknowledge the emotion. I can see that that has made you very angry. Then validate the emotion by letting the person know that you understand the emotion was appropriate. I can understand how that would make you angry. And then give an empathic response. Respond in a way that shows you have seen the emotion and that you can understand it. I am sorry this has happened and I understand how it would make you feel that way. I know what you're saying. That must have been very difficult. So you are responding to their emotion in a very empathic way. You understand and you accept the emotion. And as mentioned before, do not put the blame on anyone and do not find excuses. Just accept the emotion and that will be enough for the patient. What the patient wants is somebody to listen to them.